others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Astrid Pawlowski from Argentina, and she's going to lecture us on bispecific antibodies for relapsed refractory NHL. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Astrid Pawlowski from Argentina. All our discussions were themselves very eminent hematologists and medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 2nd of June 2024, from 11:30 a.m. Indian Standard Time, we have Dr. Pushpanjali Oja from Ranchi speaking to us on diagnostic challenges in hemophilia care, past, present, and future. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Aditi Shah Kaskar from HCG Hospital, Borivali, Dr. Aditya Jandial from Homi Baba Cancer Hospital and Research Center, Mulanpur, Punjab, Dr. Aishwarya Raj from Shelby Multispecialty Hospital, Ahmedabad, Dr. Alim Jan from Saudi Arabia, Dr. Amber Garg from DKS Hospital, Raipur, Dr. Amrit Kaur Keller from Kokilabel Dhirubhai Ambani Hospital, Mumbai, Dr. Ankur Ahuja from AFMC, Pune, Dr. Asha Shah from Holy Family Hospital and VSES Hospital, Mumbai, Dr. Asraful Haq Chaudhary from Dhaka, Bangladesh, Dr. Avritya Bavija from Himalayan Institute of Medical Sciences, HIMS, Dehradun, Dr. Chandrakant MV from Narend Hospital and RN Tagore Hospital, Kolkata, Dr. Chirag Trivedi from Christian Medical College, Vellore, Dr. Deep Kala from SGPGI, Lucknow, Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj, Dr. Gopinathan M from MGM Healthcare, Chennai, Dr. Hamza Dalal from Fortis Hospital, Mulund, Mumbai, Dr. Hiltha Diljit from Government Medical College, Kozhikode, Kerala, Dr. Neemia Thanda from North Okalappa General Hospital, Myanmar, Dr. A.R. Jaswanthini from Yashoda Super Specialty Hospitals, Hyderabad, Dr. M.I. Kadri from Srinagar, Dr. Meena Verma from BLK Max Hospital, Delhi, Dr. Meenakshi Suri from Jammu, Dr. Mohammad Mir Hussain from SKIMS, Srinagar, Dr. Narendra Agarwal from Rajiv Gandhi Cancer Institute, New Delhi, Dr. Nishad Dhakate from HCG NCHRI Cancer Center, Nagpur, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Pavan Kumar Singh from Sanar International Hospital, Gurugram, Dr. Ramaswamy NV from Aster Medicity, Kochi, Kerala, Dr. Rizwan Akhtar from SGPJ, Lucknow, Dr. Rupam Deka from AIMS, Guwahati, Dr. Sovik Saha from SGPJ, Lucknow, Dr. Sukh Prakash Sanyal from Fortis Hospital, Mumbai, Dr. Sukrit Gupta from Artemis Hospital, Gurgaon, Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur, Dr. Yi Mon Tan from North Okalappa General and Teaching Hospital, Yangon, Myanmar. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Astrid Pawlowski from Argentina. Dr. Astrid Pawlowski is Medical Director at Pawlowski Center, Department of Hematology, Punliu, Buenos Aires, Argentina. She's a specialist in internal medicine and hematology. She graduated from medical school with honors at the Universidad del Salvador, Argentina in 1997. She completed training in internal medicine at Hospital Italiano de Buenos Aires, Argentina for 5 years and continued training in Footlow as a fellow in hematology in Buenos Aires, Argentina. And today she's with us and she's going to lecture us on bispecific antibodies for relapsed refractory NHL. Well, thank you so much. Over to you, ma'am.
Okay, thank you very much. Thank you for this invitation. I'm really happy to see so many people from all around the world. And I will share with you these new treatment options that some countries have and that we will hopefully have in other countries of the world. And the point here in 2024 is how we incorporate bispecific antibodies in the treatment of relapsed refractory non-Hodgkin lymphoma. So first of all, if we look at what are bispecifics, Bispecifics are antibodies that bind surface proteins both on T cells and malignant T cells. By joining T cells, they recruit T cells, they redirect them, and they activate T cells to the lymphoma cells, provoking a large cytokine secretion. They promote immunologic synapses between these two cells, resulting finally in the apoptosis of B cells. And just as an important point, they bind to a different epitope on CD20 as the CD20 antibodies that we are used to use, like rituximab and obinutuzumab. From the beginning, the first bispecifics that we've learned about was the blinatumomab, which was an anti-CD19, CD3 antibody. And now there's a large number of new antibodies, both approved in some states and in development, and most of them are CD20, or I would say all of them for non-Hodgkin lymphoma are CD20, CD3 bispecific antibodies. We've seen, or we have the latest published information has been on these 4 different bispecific antibodies. Especially, I will focus on mosunetuzumab, epcoritamab, and glofitamab, because these are the ones that have already been approved and the ones where we have longer follow-up. We can see first there's one structural difference. Glofitamab is a CD20 antibody. It has high affinity binding to CD20 on B cells by 2 different epitopes and 1 CD3. The other antibodies are very much the same in structure. They are all humanized mouse IgG1 based monoclonal antibodies. And as we go along, we will see some small difference regarding the way of application and the frequency of application, and also they have been approved by different treatments, like mosunetuzumab with steroids, epcoritamab with steroids, and glofitamab has been approved with obinutuzumab. We will now look more insight into the specific differences between them. Oops, let's see. One very important thing that we have learned by the clinical trials is what we call the adverse events of special interest, especially these 2, which are cytokine release syndromes and ICANS. These have also been present in CAR T cells, so we learned about them first in CAR T cells, but now we are also experiencing these adverse events in the use of bispecifics. What are cytokine release syndromes? Well, this is a form of acute systemic inflammatory response syndrome that can be targeted or triggered by bispecific antibodies. These antibodies attract a large number of white cells and activate these white cells, provoking a rich inflammatory cytokine microenvironment, provoking this big inflammatory disease, which will activate more T cells and produce more pro-inflammatory cytokine releases. And we can see that in many cases, this is low grade, but it can be quite important if it's not recognized and treated early. So we can see that just because the drug is present, there is a systemic inflammatory response syndrome. This has been graded. It has 2 different ways of grading, but we use what is called the ASTCT consensus grading. And this is important because it allows us to recognize the CRS, which I think is the most difficult part, is to decide whether what we're seeing is a CRS or it's a febrile neutropenia, it's an infection. And also there are very specific ways of treating depending on the grade. We will further see on that most of the CRS are grade 1 or grade 2, and grade 1 CRS is just temperature more than 38 degrees with no other symptoms. In this case, what we have to do is just to lower down the temperature and watch the patient. Grade 2 is when there is a little bit of hypertension not requiring vasopressors, and grade 3 and 4 are just more intense CRS, requiring vasopressor or vasopressin, and grade 4 requiring also respiratory help with CPAP, BPAP, or even intubation. And our challenge here is to recognize early and treat early so we don't have grade 3 or 4 CRS syndromes. As we will now see in a more detailed way, most of the CRAs are grade 1 and 2, so they are easily managed. And in the last clinical trials, we have seen prophylactic strategies to try to diminish the number of CRS, and this is done by the use of steroids and also by the use of what we call step-up dosing. We will see that in all clinical trials, they don't start with a full dose of the bispecifics, but they start with a very, very low dose weekly during the first month, and then the full dose is on cycle 2. Most of them, and also when we use glofitamab, we can use obinutuzumab to try to lower down the tumor volume, and steroids, dexamethasone, is preferred to try to diminish the CRS syndrome. The median duration of the CRS is 2 to 3 days, and there are no clear risk factors identified, but it is advised to have special care, especially when patients have comorbidities or are older than 60 or 65 because they are unable to tolerate this toxicity. And there are some evidence that with high tumor burden, there is a higher probability of having a CRS syndrome. And as we can see, one important thing is that we have a specific treatment, which is tocilizumab, which is an anti-interleukin 6, that we can use it from grade 2 onwards. Grade 1, we just consider a lowering down temperature. Grade 2 onwards, we do have to have tocilizumab. So we cannot use bispecific antibodies if we don't have tocilizumab available. And from grade 2 on, patients should be admitted to an ICU unit to have close follow-up of these patients. After tocilizumab, if there's no response, we start using dexamethasone. So there are very, very clear guidelines on how to manage, how to recognize the syndrome and how to manage. And CRS is reduced when combined with immunochemotherapy, and this is the way clinical trials are going. And the other toxicity of special interest is ICANS. ICANS stands for Immune Effector Cell-Associated Neurotoxicity Syndrome. And this is a clinical diagnosis, and it's a clinical neuropsychiatric syndrome that can occur a little bit further on after CRS. CRS can be triggered to half an hour after we do the treatment, and this can occur days to weeks following the administration of certain types of bispecific antibodies. With these antibodies, most of them are just grade 1 and 2, maybe just feeling a little dizzy or having a headache, and there are mainly no grade 3 or 4 ICANS. Here also the important thing is to recognize this, so we have to have constant neurologic exam of our patients. And the important thing also is to recognize this and not having and differentiating this from CRS, because it is not recommended to use tocilizumab. It is recommended to use steroids. So why do these ICANS happen? Well, we still don't know why there is this neurologic syndrome. There's no evidence that monoclonal antibodies actually cross over and are found in the cerebral fluid. There's activated T cells or increased pro-inflammatory cytokines are also not found in CSF in patients experiencing neurotoxicity. Also, we know that moral cells of the brain do not express CD20, so there's still no understanding of why there's an inflammatory procedure in the brain. And neurotoxicity with antibodies is less common and generally lower grade than CAR-Ts. As said before, more frequently headaches or dizziness. And although we do have these, there are no specific restrictions that we have to do to our patients. For example, we do not have to advise them to not drive or not go to work. We just have to make sure that we do a good interrogation for our patient. And happily, we can see that the incidence of CRS and ICANS is low, and when presented, it's usually grade 1 or 2. And we can see in orange that it is very rare to see grade 3 CRS or ICANS with glofitamab and epcoritamab. What other toxicities of interest do we find? One is tumor flare. Tumor flare is the enlargement of pre-specific or of a pre-existing tumor. This is not, and this is by an inflammatory site in the place of the tumor. This can be, and we had very difficult cases, this can be very difficult because sometimes it is within the neck, or it also causes pleural effusion or pericardial effusion, being clinically difficult to manage. Another toxicity is cytopenias. Well, we don't know whether this is directly done by bispecifics or whether it is multifactorial, because many of these patients had already received 2 or 3 or more treatments with chemotherapy. And infectious complications are also present. And if we look at the clinical trials, there's a lot of the small proportion of people that died within the clinical trials, a proportion died of COVID infection. So be very careful, and we advise patients to have a COVID vaccine before. Also prophylaxis with Bactrim and also prophylaxis for zoster is recommended. So now going specifically onto diffuse large B-cell lymphomas, we've known that the appearance or the approval of CAR T-cell in diffuse large B-cell lymphoma has dichotomized management in countries where there is actually the possibility of having CAR T. So if patients relapse after first-line chemotherapy, and if they relapse within the first year, which is most of the patients, and are eligible for CAR T, now guidelines in North America and Europe recommend second-line CAR T-cell, this is axi-cell or lyso-cell. If patients relapse after 1 year, then they go on to salvage chemotherapy and autologous stem cell transplantation. If patients relapse of any of these therapies, then they have these new options, which are either CAR T-cell in third line, if they had not previously received it, polatuzumab vedotin, tafasitamab, loncastuximab, selinexor, and now the approval of these bispecific antibodies. So if we look at what is going on in the rest of the world, when do we use CAR T therapies in second-line setting? We use them in primary refractory disease or remission lasting less than 12 months after first-line therapy, or in second-line patients who are ineligible for autologous stem cell transplantation, but eligible for CAR T. We know that for CAR T, it's much easier to get CAR T than to get autologous stem cell transplantation regarding comorbidities and also regarding the control of the disease. The choice of the product depends on the slots available. It's the same to use axi-cell or lyso-cell, and the median follow-up shows more or less the same results. And the use of targeted approaches like pola-BR, tafasitamab, lenalidomide should be considered for patients who have received already autologous stem cell transplantation or are CAR T-C ineligible. But there are limitations, not only in countries like ours, but also in North America and Europe. There are limitations to CAR Ts because these are personalized therapy. They're still working on trying to shorten down manufacturing time so patients don't progress while waiting for CAR Ts. There is toxicity still related to these procedures, cost, and also it is unavailable for most patients around the world. So in many countries, and I think India is not still having CAR Ts, neither is Argentina. So in many countries, there's still an unmet medical need for an effective, well-tolerated, and convenient therapy for relapsed refractory diffuse large B-cell lymphoma. And this is where bispecifics can have a role. We had 2 important publications in December 2022. one in New England Journal of Therapy, authored by Michael Dickinson, with glofitamab for the use of relapsed refractory diffuse large B-cell lymphoma, and the other one the same month with epcoritamab, presented by Catherine Thieb-Lemond. We have seen in the last year the extended follow-up of the phase 2 trial of glofitamab in relapsed refractory diffuse large B-cell lymphoma. And now we will look at some of these differences. This is an expansion cohort. They included patients with diffuse large B-cell NOS, high-grade lymphoma, transformed follicular lymphoma, and primary mediastinal B-cell lymphoma that had received at least 2 lines of therapy. The primary endpoint was CR, and the other key points were overall response and duration of response. So when using glofitamab, this has been approved with a prephase of obinutuzumab, as said before, to try to lower down the tumor burden and try to diminish the probability of having CRS. Cycles are every 21 days, and glofitamab is given IV. And another big difference is that this clinical trial was set with a definite amount of cycles, with up to 12 cycles. So this is giving every 21 days, IV, and for up to 12 cycles. And we can see these results, which are encouraging. There's 40% CR rate. The overall response is 52. And with a median follow-up, the ongoing CR responses are 68%. So we can see this is the duration of the CR done by the IRC. So 70% of the patients in CR at the time of this analysis were still on CR. So this is important to look at, and we will see in these slides. So these slides, I think, are very important in the management, because the authors reported the PFS and overall survival regarding response at cycle 3. Patients were evaluated at cycle 3. If patients were in CR at cycle 3, the PFS at 18 months was 72%. But look at the patients who were not in CR, the curves lower down very quickly, and at 6 months, the PFS is 20%. So who are the ones that really benefit from these? Are the ones that have an early CR. Most of the CRs are within the first 3 months. It is very rare to see transforming PR to CR with further follow-up. So regarding that these drugs are expensive, we know that if patients has a CR at month 3, then they are the ones who have best benefit. And this is translated in a very important way to overall survival. Patients in CR are 80% alive at 18 months. And this is also seen, of course, regarding the response at end of treatment. We can see that patients that did not respond, that had a progressive disease in the red curve, really had no benefit. Patients with partial response also had no clear benefit. And these 40% that had a CR are the ones that actually survive longer. And most patients in CR, 92% of the patients in CR are alive at 12 months. And we can see, we need further follow-up, but we can see a plateau both in PFS and overall survival for patients in CR evaluated by PET-CT. Regarding the safety profile, it is what we just mentioned. There is a high proportion of CRS, 64%, but we can see that 60% are grade 1 and 2. And there's also some infections, and we can see that there were no other important things other than what we have seen. So the conclusion of the investigators are that glofitamab, with a longer follow-up, continued to show durable responses in patients with heavily pretreated relapsed refractory diffuse large B-cell lymphoma with a median of 18 months, and that most patients in CR at end of treatment remain in remission. So investigators conclude that this data support the potential for favorable outcomes with fixed duration glofitamab for this group of patients. And also at the same time, we see the results of the epcoritamab trial. And what are the differences? First of all, that this is giving subcutaneous. the cycles are every 28 days. They are to try to diminish the CRS or the adverse events. The trial was designed with steroids with 20 milligrams for 3 days, and epcoritamab is giving subcutaneous and until progressive disease or an unacceptable toxicity. So we have the benefit that it is subcutaneous, but this trial suggests that we should go on with treatment until progressive disease. Once again, a large proportion of patients were included. They included all different disease subtypes: diffuse large B-cell, de novo or transformed, high-grade lymphoma, primary mediastinal B-cell lymphoma, and grade 3B follicular lymphoma. A large proportion of them, about 40% of them, had already received CAR T cell therapy. This is important because in places where they have CAR T, as we saw in the algorithm before, CAR T is indicated before bispecifics. So once again, the CR for this group of patients is 39%, and the median time to response is 1.4 months. So we see again the same efficacy and the same time to response. Most patients, the median time to CR is 2.7 months. So if we evaluate patients after 3 months, we will very much have a good view of the prognosis of this patient. And the median duration of response was 15.5 months and not reached for patients who were in CR. There was this is the median overall survival were not reached, and patients estimated to be in CR at 15 months is 80%. So again, a lot of the same efficacy as what we see in glofitamab. Considering adverse events, also there's no difference regarding what we just said. And look at in this trial, there were 2 deaths, and one of them was related to COVID-19, and the other ones related to ICANS, but this patient was very complex and there were several confounding factors. So overall, bispecifics lead to an impressive CR in diffuse large B-cell lymphoma. And regarding this response, on May 2023, the FDA approved epcoritamab after 2 or more lines of systemic therapy. And then in June 2023, also glofitamab was approved with the same indications after 2 or more lines of systemic therapy. So now, in places where both CAR Ts and bispecifics are available, the proposed algorithm is to use first-line therapy if patients relapse within the first 12 months or are refractory. Second line is CAR T. If patients relapse after 12 months, then we go on to platinum-based chemotherapy plus consolidation with autologous stem cell transplantation. And when patients relapse, if they are CD20 or CD19 for third line, it is also CAR T, glofitamab, and epcoritamab. If we are not available, then we can use all of these other combinations that we can also talk about. And in a dotted way with a large interrogation mark, whether these patients should consolidate with allogeneic transplant. So there's a big debate whether CAR T versus bispecifics. Actually, I think this is a false dichotomy because none of the strategies cure all patients. So we will probably need both for patients if we ever are available to have these. What about follicular lymphoma? Well, follicular lymphoma has also shown very impressive results, especially with mosunetuzumab as monotherapy. Once again, we see the step-up dosing to avoid CRS. Here, all patients with follicular lymphoma that had received at least 2 lines of therapy were included, and mosunetuzumab was given IV, but now it can be given subcutaneous. And look at cycle 1. They start with 1 milligram, then they go on to 2 milligrams, and then they go on to full dose 60 milligrams, which is given also on cycle 2. And then they go on with 30 milligrams from cycle 3 onwards. The primary endpoint was CR rate. These patients were heavily pretreated. We can see that the median lines of therapy was 3. Some patients have received up to 10 lines of therapy. A large proportion of patients had been refractory to last line of therapy, and almost half of the patients had relapsed within the first 24 months of last therapy. And again, we see that those patients that achieved a CR have a very good duration of response. The 24 months of duration of response for patients in CR is 65%. So also for an unincurable disease and for patients who have more than 3 lines of therapy, this is also a very good option. And here the authors compare the median duration of CR of mosunetuzumab as monotherapy compared to prior therapy. We know that in follicular lymphoma, patients have a shorter PFS after each line of therapy. Well, with bispecifics, this is not real. The median duration of response was not achieved, not reached, and there's an important difference regarding the last PFS or duration of response to last therapy. So FDA also approved mosunetuzumab in December 2022 for relapsed or refractory follicular lymphoma after 2 or more lines of therapy. And also in this year, odronextamab was approved as a fast track designation both for follicular lymphoma and diffuse large B-cell lymphoma, showing also the same efficacy and toxicity. But what is the future? After we learn about the efficacy of monotherapy with these drugs, the next step and what's going on now is the combination of any of these bispecific antibodies with chemotherapy. So we have I have had experience including patients in clinical trials with mosunetuzumab plus POLA, which was randomized versus R-GMOX for relapsed refractory diffuse large B-cell lymphoma. We also have epcoritamab plus standard of care for follicular lymphoma. And now we are moving on to first-line therapy. So as we learned, third-line bispecifics were approved as monotherapy. Second line, they're in clinical trials combined with standard of care, for example, Glofi plus Hemox versus Hemox, Epcot plus BR versus GMOX. And now we are including patients in clinical trials from first line. Now we have open in our center this clinical trial, which is called SkyGlow, which is glofitamab, POLA R-CHP versus POLA R-CHP. And we also have EPCO, R-CHOP versus R-CHOP. So we will see if these drugs eventually improve first-line CR and PFS, or that we can cure most patients with first-line therapy. So bispecific antibodies are promising efficacy in patients with relapsed refractory non-Hodgkin lymphoma. CRs are achieved in 40 to 60% of patients. Responses, especially CRs, are durable. These drugs are feasible in the community. They are easy to handle. Adverse events of primary interest occur early, and most of them are low-grade CRS or ICANS, and they are potentially effective in high-risk patients. They have the same efficacy in patients that have received prior CAR-T or that are double refractory or that are primary refractory to chemotherapy. And we will see what are the results of the ongoing trials, but they can certainly be combined with standard of care chemotherapy. And when we use them, there are no difference in CR between patients that have previously received CAR-T versus patients that have not received CAR-T. What is it that we are still lacking? We don't have long-term follow-up, so we can't not say that these patients are still cured. We don't have data on long-term toxicity. Also, we will see if continuing therapy until progressive disease is also feasible, not only regarding toxicity, but also regarding the economic toxicity that this can have. And I think that with these new strategies, there's not a matter of picking a winner, but actually the challenge is to see how we sequence this therapy if we are available to deliver this in our patients. So as developing countries, we are now facing new challenges in diffuse large B-cell lymphoma. And this is that with a better understanding of diffuse large B-cell lymphoma, this is leading to new diagnostic and treatment opportunity. But we face the challenge of providing this treatment in the correct time and trying to make this salvage therapy available worldwide. They are not approved in many countries around the world. I think that in the countries that we are dealing with within this conference, many countries do not have this available. So our greatest challenge lies in trying to prevent that disadvantages lead to a widening gap in therapeutic opportunities between people with different economical resources. So I think this is where we are facing this big challenge or this big disappointment that in many countries there are better therapeutic opportunities than in other countries around the world. So I want to thank you very much. We can now have a discussion. These are three organizations in which I am involved, which are dedicated to teaching about lymphomas. They're all free and easily accessible online. And I'm happy to take any questions. And this is my city, Buenos Aires, in spring. Thank you very much.
Thank you so much, ma'am, for that fantastic lecture and throwing us light on this bispecific antibodies on relapsed refractory NHLs. Thank you so much. That was fantastic. And I now request all our discussants to please put the raise hand sign so that we can start our question and answer session with Dr. Astrid Pawlowski. Yes. Dr. Gopinathan, your question.
Good evening, ma'am. Thanks for the comprehensive lecture. My question is, in our DLBCL cohorts, we have included these patients of high-grade B-cell lymphoma. Have we included any patients with Burkitt's in such for bispecifics? Whenever we have refractory Burkitt's lymphoma, have we used bispecific antibodies in those set of patients?
Okay. Thank you very much for your question. No, actually, none of these clinical trials included Burkitt patients with Burkitt lymphoma. Also, they excluded patients with CNS involvement. And they did not, these clinical trials did not also include mantle cell lymphoma. So we are still missing to know what will happen with these patients. But I haven't read anything about Burkitt and bispecifics. Not sure whether anyone else in the panel has experience or knowledge about this.
And second thing is regarding the sequencing between the therapies, between CAR T cell therapy and bispecific antibody. Why we have placed such, like we need to have CAR Ts before bispecific antibodies? Any particular reason where we need to allude to, ma'am?
Well, I think this was a matter of the design of the trials and also on the arrival of the therapies. CAR T cell has, this month, it was 10 years since the first patient received CAR T. So CAR T arrived earlier. So that's why many of the bispecific clinical trials include patients that have already received CAR T. But there is some knowledge in CAR T that patients that have received bispecifics may have a lower response to CAR T, but in patients that receive, that have already received CAR T, there is no difference in efficacy for bispecifics. But I think this was a matter of at the time that each therapy was approved. I think that when both of these therapies are approved, we will learn more about the sequencing. What investigators say is that there's still no long-term follow-up with bispecifics to actually see if these patients are cured. Another thing is that we know that CAR T is just one shot, one treatment. Bispecifics, as we've seen, some have been approved for a long term. So also that is a disadvantage. But I also think that bispecifics may be able to reach a larger proportion of patients. It is easier to have access to bispecifics than to CAR T. So we will see in the future how this is distributed. Maybe in some countries around the world, we will have access to bispecifics before CAR Ts. I think that is what will happen in Argentina. It might be approved epcoritamab this year and glofitamab at the beginning of next year. And I don't think we will have CAR T available soon. And if we do have CAR T, then it will be for a small proportion of patients. It is a very expensive and complex treatment.
What specific variables do you look at of predicting non-response to these bispecifics? If at all, what are the specific in your clinical practice, or what have you come across, like the specific factors where we can determine this drug may not work well?
Okay, there has been a subgroup analysis in each clinical trial, and actually all subgroups regarding age, regarding histology, regarding bulky disease, regarding stage, all subgroups did not show any difference for a response to therapy. So today we don't really, we can't detect a group that will actually have better response or a group that will have no response. I think that, as I showed you in the presentation, what we can do is quickly detect those patients that actually do respond and will be benefited from these therapies. Maybe after only 3 cycles, we can already know whether this patient is in CR and will actually have a benefit or not. But we don't have a pre-treatment biological or clinical factors that can give us a prognosis of response.
Yeah, just a last question, sir. One more thing, before starting this glofitamab, I was thinking at the trial design, we use obinutuzumab before glofitamab. So most of our patients are previously multiple times exposed to rituximab. So in case of the glofitamab, if you're purchasing through some compassionate basis and we are making the drug available, is it necessary to definitely do a glofitamab, obinutuzumab, and then do only glofitamab, or we can directly give glofitamab?
Well, I think that the main reason for adding glofitamab was not to improve efficacy, but actually to diminish the risk of CRS.
Yes.
Because at the time, we are trying to go along exactly like the clinical trial, but I think you really need to use something to lower down the probability or the grade of CRS. With glofitamab, obinutuzumab was used also because the drugs are from Roche, from the same lab. But we actually do need to use something to diminish CRS syndrome, because otherwise CRS can be grade 3 or 4. So something has to be used, and I think that we use glofitamab. We used obinutuzumab when using glofitamab.
Thank you, ma'am. Yeah.
Thank you.
And to be able to have the patient either in the hospital or staying within 1 hour range of the hospital for the first doses, especially for the first full dose. That is when most CRS are seen.
Thank you. I think, ma'am, we are not able, yeah. Ma'am, are you there?
Hello.
Yeah, just a minute. Ma'am, are you there? We have lost her actually. Just Dr. Hitha, just be ready with your question. We will let her join in a few while. Yeah, she has joined back. Yeah, you're muted, ma'am.
Yes.
I'm sorry.
So, Dr. Hitha, your question, please.
Okay. Thank you, ma'am, for that very excellent talk, and that especially that algorithm regarding the sequencing of therapy. Ma'am, I have 2 questions. The first one, How many median number of cycles of this bispecifics you have to give to have a sustained CR in a patient who have relapsed after CART or autologous stem cell transplant? The second question is, what is the infectious prophylaxis do you give for these bispecific antibodies?
Okay, very good answers. So one part of the first question is that if patients did not have a CR by 3 or 4 cycles, most probably the patient will not have a CR eventually. And your question is, how many do we need to have a sustained CR? Well, we don't know that, because we know what the clinical trials have shown us. We know that with glofitamab, 12 cycles are good enough, and with epcoritamab is until progressive disease. I think that in the future, and this is just a personal opinion, it is very difficult to do treatment until progressive disease or toxicity, because maybe a proportion of these patients will be cured. So how long are we going to maintain this treatment? Also because it's expensive, and also because we have the patient exposed to treatment every month. So I think that for now, we are going to have to respect the indications of the clinical trials, but maybe in the future, the same as happened with nivolumab and with checkpoint inhibitors in Hodgkin lymphoma, in the future, with clinical experience, we might be able to say that maybe after 6 months or after 1 year of CR, it is safe to stop therapy. But for now, we don't have any other data other than what has been reported in the clinical trials. And these patients are doing whatever the clinical trial was designed, either stopping after 12 months for glofitamab or going on for epcoritamab.
Okay, thank you, ma'am.
Thank you, Dr. Geeta. Dr. Kaustubh Shekhar, your question, please.
Thank you, ma'am, for the comprehensive talk. I just wanted to ask one question. It is regarding, do we look for the percentage of CD20 positivity or cutoff? Is there any specific cutoff before starting the therapy with bispecifics?
No, not at all. We don't look. Well, no, there is no cutoff. The clinical trials has an inclusion criteria demanding CD20 positive lymphomas, but there's no specific cutoff. I don't think we will ever have specific cutoff, because we're not used to use these cutoffs for the treatment of anti-CD20. But they did include patients who had CD20 positive diffuse lymphomas, both for follicular or for diffuse large B-cell lymphoma.
Okay, thank you.
Thank you, Dr. Kaustubh. Someone from iPhone, your question, please. Yeah. Dr.
Sorry.
No, it's nice. It's nice when you put on your camera, because I can see you.
Yes, sorry. Thanks for that lucid talk. I want to ask one question. Those patients who are having relapsed refractory DLBCL, so those patients who have failed CAR T-cell therapy, so where do you place as compared to the bispecific antibodies and monoclonal antibody tafasitamab? So what is the preferred option for those patients? What is the opinion for those patients?
Do you mean the preferred option of the different bispecifics, or within bispecifics or CAR T?
So between CAR T-cell therapy and bispecific antibodies, those patients who have failed CAR T-cell therapy, DLBCL, relapsed refractory DLBCL, failed CAR T-cell therapy. So now, what is your preferred option? Either the tafasitamab monoclonal antibody or bispecific antibodies?
Well, I think that in the future, I think maybe the preferred option will be a combination of chemotherapy plus bispecific antibodies. I think that this will, but we still need to have further follow-up on the clinical trials. Today, it is only approved as monotherapy for bispecific antibodies. And as said before, failing to CAR T is not a bad prognostic factor for efficacy to bispecific antibodies. And regarding which specific bispecific antibody, actually there's practically no difference in efficacy. So I think that whichever is available will be good enough. We don't really need to choose between the bispecifics regarding toxicity or regarding efficacy.
Thank you for that.
Thank you, Dr. Upendra Sharma. Dr. Mir Hussain, your question, please.
Yeah, sir. Thank you. Thank you. It was a nice presentation and a very valuable to us about the treatment of this subset of very difficult to treat. So my just a comment and a question: can you combine them with immunotherapy because it will recruit more T cells? Do you feel that in the future a combination of these bispecific antibodies with the immunotherapy agents will lead to more responses, more CRs? And second is, if we combine them with cytotoxic chemotherapy, do you feel that giving agents which lead to T cell cytotoxicity, the efficacy will be compromised?
Okay, so the first question is whether I think that these can be combined with other immunotherapy.
Yes.
Okay, well, I think the combination of different bispecific antibodies has no reasonable efficacy because they are practically the same. Regarding if that's your question, I think that they can be combined with anti-CD20 antibodies, as mentioned, and with chemotherapy. Obviously, they cannot be combined with, well, there are some reports, or I heard about some expert talking about the probability of doing CAR-Ts directly after bispecifics, or the other way or consolidation with bispecifics after CAR-Ts. This is very, very soon yet to know about these responses, about this combination of both. That would be a very, very expensive treatment to do both, and one after the other. But we will see. I don't think there's enough experience to see if this is a benefit. What we do know, and I have just showed you, is that patients who do not achieve CR, both for CAR-Ts and both for bispecific antibodies, have absolutely no benefit. So maybe for patients in PR, for both treatments, you can, maybe in the future, there will be a clinical trial showing the combination or the consolidation of one and the other for those patients who are not in CR. For patients who do have CR, both for CAR-Ts and for bispecific antibodies, the prognosis is quite good. So I'm not sure whether combining a new therapy in this subgroup of patients is good.
Another question is regarding the combination of bispecific with cytotoxic therapy. Whether the T cell function will be diminished by adding cytotoxic therapy when we combine the two? That's the second question.
That is a very good question, and I think the clinical trials will show us. I think the hypothesis is that there will be a benefit combining both because the clinical trials are being designed like that, but we still have to see the results. The clinical trials are still incorporating patients, so we have absolutely no preliminary results to see this. What I can tell you is that we did use the combination of within clinical trials, both of mosunetuzumab plus polatuzumab, and also epcoritamab plus lenalidomide. So, and it is thought we'll still need to see the results because we're just including patients, but I think these are good combinations. Afterwards, I'm sure there will be just, monotherapy versus combined therapy. So,
any other question?
I think these. No, I think these. No, sorry. Okay.
We cannot hear your voice.
Sir,
Dr. We cannot hear your voice properly. If you can type your question in the chat box. Okay. So there are some questions, ma'am, from the audience. Dr. Babita Sodi wants to know if there is no cutoff for CD20 positivity. That means if there is no diffuse positivity, whether focal positivity for CD20 are also selected for antibody treatment?
Yes, there are no cutoff for CD20. Absolutely no, no further things other than CD20 positive. That is good enough. As long as there are CD20 positive, patients were included. And I have not seen any analysis in subgroups regarding the percentage or a cutoff for CD20. I don't think that will ever be made. I think as long as there's CD20 positive lymphomas, they can have this.
Thank you, ma'am. Another question from Dr. Yi Montent. According to your experience, which bispecific antibody do you prefer? And the second question is choice of bispecific antibody in elderly populations who are between 70 to 75 years of age. And have you experienced any side effects in this age group with bispecifics?
Okay, so thank you for your question. So regarding which we prefer, well, I don't have a preference. What I said, we have used this within clinical trials, so we use whichever clinical trial showed us. I think the preference will be regarding glofitamab is IV, so that is, you know, a little bit more complicated than doing subcutaneous. Patients that have subcutaneous treatment, they get the treatment in 3 minutes, and then after cycle 2 or cycle 3, if there has been no adverse events, you can choose to not give any prophylactic treatment. So patients come in and then they go out very early. It is very rare, we have to be aware, but it is rare to see CRS after the first cycles. So I think that regarding which ones do you prefer, it is a lot easier to give subcutaneous than IV, but we will see. And I don't think so far there has been no difference in efficacy. And regarding elderly patients, these patients do not show a larger proportion of adverse events, but yes, they have less tolerability to adverse events. So for this group of patients, we are very careful. In our experience, we have admitted to our institution these almost all patients during the first cycles, and we are very, very careful that we can watch these patients for the first 48 hours after receiving the step-up dosing and the first full doses. So I think it is the biggest challenge is to recognize adverse events, CRS especially, and to differentiate CRS from other things, especially from neutropenic infections or from other things. I think in our experience, it has been a learning experience to do the differential diagnosis, because in most cases, when they have CRS, which is fever and hypertension, we also start with antibiotics. We also do cultures. We start with antibiotics. We treat the patients as we would if they had not received bispecifics, but we are aware and we give tocilizumab early if patients have prolonged CRS grade 1 or if they have CRS grade 2 with hypertension. So for patients, for elderly patients, we are more careful about being very quick in responding to adverse events.
Thank you, ma'am. Another question from Dr. Roshni Bhagwat Pandey. Do bispecifics cross the blood-brain barrier?
I'm sorry, can you say the question again?
Do bispecific antibodies cross the blood-brain barrier?
No, they do not cross the blood-brain barrier. So there are no wide experience in CNS lymphomas, but different studies have shown that they are not found in the cerebral spinal fluid.
Thank you, ma'am. Another question from Dr. Mir Hussain. why immune checkpoint inhibitors have not been so successful in non-Hodgkin's lymphoma as compared to Hodgkin's lymphoma.
Okay, so we go into a different topic, but a topic that I really have a lot of interest, and this is due to the way that the Hodgkin cell actually allows itself to grow. The Ritz-Stenberg cell has a very special immune effect, stopping the inflammatory disease from being active. So this is a very special way of surviving for the Hodgkin lymphoma cell. You know, they actually block the immune system to be effective. So with the checkpoint inhibitors, this anti-PD-1 goes directly into one of the mechanisms of survival of the lymphomas, of the Hodgkin lymphoma cell, which is not seen in the non-Hodgkin lymphoma. That is why in Hodgkin lymphoma we have very few tumoral cells and a very large inflammatory but ineffective background. So all of that inflammatory background that we see in the biopsy, it is actually being ineffective because it is being stopped by different mechanisms of the Hodgkin lymphoma cell. So that is why this is the checkpoint inhibitors are particularly efficiency in Hodgkin lymphoma, other than in all other lymphomas.
Fantastic. That was a brilliant answer. Another question from Dr. Raghvendra Rajeshwarkar. Can allotransfusion of T lymphocytes from immunocompetent normal individual have any effect on non-Hodgkin's lymphoma?
Wow, okay. Well, I really don't know this answer. That is a very, very good question, but I have no experience. I can guess that, as we all know, all of these diseases are not only the mechanism of the disease is not only generated by the tumoral cell, but also by a big inflammatory or background or microenvironment that is also helping the tumoral cell grow. So I think that as we are seeing now, many therapies are directed to the microenvironment and not to the tumoral cells. So I am not sure whether giving B cells will be effective. Maybe, you know, changing the inflammatory microenvironment might be useful. But I think that's a complex question that I cannot really answer. Thank you very much for your. I'm not sure if anyone can have another opinion or suggestion. I invite people in the panel to give their opinions.
Sure. Another question from Dr. UN Naga. This is regarding the BiTE therapy. If it is in the situation that BiTE is not available in our practice, which is very common in India, which immunotherapy in combination with chemotherapy do you prefer? Anti-CD79 or anti-CD30 in case of CD30 positive refractory DLBCL?
Okay, so as said before, we also don't have commercially available bispecifics. So what we do have available and what I do have experience with polatuzumab, okay? So I think that is one clinical trial that has shown a positive result of Pola BR versus BR. So we are deciding to use that. That is my experiences with polatuzumab. Other new drugs have not been approved in Argentina, and I have no experience in clinical trials with these other drugs. So that is what we use for relapsed refractory diffuse large B-cell lymphoma, other than bispecifics. The problem with this combination is also that most patients are not cured with this combination. Okay, we are giving PFS, but the overall survival is not very high. So maybe this can be a bridge to auto transplant if patients have not achieved a CR and were not able to receive CR, or to allo transplant if patients have already received an auto transplant. So I think it's an opportunity it's a high opportunity obtaining a CR to see if we can consolidate the patient.
Thank you, ma'am. I've finished all the questions from the audience. Any discussion want to ask any other question to ma'am? So I think there are no more raised hand size and no more hand raise and no more questions from the audience. Well, thank you so much, ma'am, for that.
Thank you very much for your great organization. I've been invited almost 6 months ago and everything was perfect. And it's a pleasure to talk to people from the other side of the world. And I hope we get to meet each other sometime. Thank you very much.
Thank you so much for that fantastic and wonderful talk. And what a wonderful question answer session. Thank you, ma'am. Thank you so much for being with us.
Thank you to all. Bye-bye.
Thanks a lot. Bye.
Bye-bye.